Hello, good afternoon. Welcome. We're going to get started right on time. My name is Audrey Vernick. I'm the Director of Patient and Family Advocacy for the Pediatric Epilepsy Surgery Alliance, and I'm honored to be able to introduce Dr. Adelson today. David Adelson is currently at Phoenix Children's Hospital, but will be at West Virginia Children's in the Rockefeller Neurosciences Institute, and if I mess that up, he's going to correct me, I hope. He spoke at our conference this summer, and one of his colleagues described him as an international neurosurgery rock star, so you're really in good hands here today. Dr. Adelson he received his undergrad and medical degrees from Columbia University. He completed his neurosurgical residency at UCLA in 1993 under Donald Becker. He then completed his pediatric neurosurgery fellowship at Children's Hospital of Boston and Harvard Medical School under the guidance of R. Michael Scott and Peter McElblack. Sorry, that's how it's written. Finishing in 1994, he then joined the faculty at University of Pittsburgh in the Department of Neurosurgery with Peter Janetta and L. Dade Lunsford. He moved quickly up through the ranks from assistant professor to full professor with tenure in 2003. In 2007, he was awarded the A. Leland Albright Endowed Chair as professor of neurosurgery, pediatric neurosurgery at the University of Pittsburgh and Children's Hospital of Pittsburgh. So suffice it to say, you're in good hands, and welcome, Dr. Adelson.
You get some short classic bios there. So, well, we've got a huge crowd here, so if you ever want to move forward, please feel free. In the program, they had originally wanted me to talk about neuromodulation, but felt that what they would like was a more broader topic for families. And so you can see my title that just didn't make it to the printers in time. So we're going to just talk about where we're at right now with regards to the innovations, not only in the diagnosis of epilepsy, but the surgical treatment. And I think you'll see that there's some exciting stuff going on that'll be really quite interesting to all of you. I should say it's interesting to me. Hopefully it'll be interesting to you all. So I do have some disclosures, and you've seen the companies that are here exhibiting. These are, I work as a consultant occasionally for Medtronic, mostly in the robotic area, not really in any of the other areas that I'll speak to here today. And then LivaNova is the group that has developed vagal nerve stimulation, and so I will speak a little bit about their product. Just for those of you who don't know, interestingly enough, surgery for epilepsy has been around since the 19th century. So in the late 1800s, there were neurosurgeons doing surgery for patients with epilepsy. So it's not something new. And if we look through the history, while most of the treatment of epilepsy has been published in adults, we do know that good and excellent outcomes can be achieved, particularly in children. And since epilepsy still remains, unfortunately, a very, very common neurological disorder of childhood with an incidence of about 2%, we really do have to consider surgery when medications or diet or alternative treatments fail. We have to look at the whole armamentarium of what we're trying to achieve. Now, there are a number of different challenges, and the big challenge is in order to do surgeries, you need to know where to go. And so being able to identify where the seizure focus is and the zone and how it spreads is really integral in our ability to then potentially treat that epileptic syndrome. So clearly, it's identifying not just where the epilepsy syndrome, where the seizures are coming from, but then what are the appropriate patients that may potentially benefit from surgery. And so how do we then start to define the optimal surgical approach for those patients? And then what I hope to go over today is the evolution, particularly since I've been in this field now for over 25 years. There have been a lot of advances in this area, and so I think very excitingly there's great opportunities for many children that didn't exist, particularly when I started my career. So I just hope that I can impart upon you today that we do know that the best outcomes come when we're able to accurately localize where the seizures are coming from and how they spread. We do know that in the past, particularly in the last 5 years, that we've had really unique innovations in being able to better diagnose these patients with improved accuracy. We also now have much more minimally invasive approaches surgically in order to not only leverage that accuracy, be able to target where those seizures are coming from, but now use much more minimally invasive approaches in order to optimize the outcome for those patients. And then we've got a lot of new techniques, both in surgical intervention as well as in neuromodulation, that really allows us great opportunity to treat patients that we couldn't treat previously. And so that's what I hope you'll take away from this today, really to understand where we're at and how we've grown in the last number of years. I was last at this conference 3 years ago, right before the pandemic, and it's when I started to go through the talk that I gave there, and then started looking at how I wanted to approach this one. I really had turned over almost 60-70% of my slides, and that's how much things have changed since that time. So many of you are aware, and I don't need to belabor it for this audience, but the reality is once we get past 1 or 2 medications, the likelihood of obtaining seizure freedom is in the range of about 1 to 4%. And so really what we're dealing with is a third of patients won't have a response to medications, diet, or other treatments. And so really we're talking about a group of patients that don't have other alternatives. And so really in those instances, that's when we need to consider surgical intervention. We also know that there's a significant treatment gap. Now, not all patients who are refractory are going to be appropriate patients, but clearly we could do better than what we have now. So if we look at the US in general, and we say there's about 3 million patients living with epilepsy, about 1 million of those patients, so about a third, are intractable. And the reality is if we look at all of the epilepsy centers across the US, there's only about 7,000 to 10,000 surgeries being done per year. Well, if you sort of think about that, the chances of us ever catching up for those 1 million patients is very unlikely. And so that's why there's such a significant treatment gap for these kids and for adults. And as you can see here, over here to your left, there's about 150,000 new cases of epilepsy each year, and if we calculate it in 50,000, and we're only doing maybe 10,000, we're not even keeping up with all the new cases. So to catch up is really a significant gap, and as a result, as you can see, many times patients will wait upwards of 20 years before getting appropriate care. If we said that about cancer, or said that about pulmonary disease, or said that about any other problem, there would be a huge outcry. And so clearly there's a huge treatment gap when it comes to epilepsy, especially refractory epilepsy. So what are the goals of epilepsy intervention? Well, it doesn't really matter whether it's medical, diet, alternative treatments, or surgery. The goals of the epilepsy intervention are to stop seizures, or at least markedly reduce them. There's not one that's better than the other. What we try to do at today's day and age is how do we interplay all of those different alternatives, medicines, diet, alternative treatments, and surgery, how do we balance those in order to get the best outcomes for the patients? And the reason is that the reality on patients who have repeated seizures is that it results in brain injuries, and it results in neurocognitive decline, and it interferes with normal function. Now, whether it's the intractable seizures or it's the toxic level of medications for many of these patients, as a result, brain function is impaired. And then if we take that down to children, trying to have a child learn when they're on enough drugs that's like taking, being on 3 martinis and trying to now function, whether it be in school or with activities, when they're so drugged up, you can see it's not just the seizures, but also the impact of medication on the developing brain that has such an impact. Well, when it comes to surgery, we know that the best outcomes come when we understand where the seizures are coming from, the types. If we can lateralize, so pick a side, and then localize where those seizures are coming from. And particularly if we can start to pick up if indeed there is some underlying abnormality that we can measure. And that's the reason I put in here the ability to visualize the anatomical abnormality. Our imaging modalities have gotten much, much better in being able to pick up subtle areas of abnormality within the brain, and I'll show those in a little bit, but also understanding that epilepsy is a functional disease. It's a dysfunction of a part of the brain that results in the children or adults having seizures. And so what we need to do is to be able to operate on an area like that. We need to be able to visualize if there's any anatomic abnormality, but also understand where the functional abnormalities are. And how do we assess that brain activity? Well, there's a number of different modalities, and those would include just even an EEG as a functional test. It's looking at the brain waves to look for abnormality. But there's also MEG and SPECT and PET and functional MRI and a lot of different modalities that allow us to get a gestalt or get a feel for how did the seizures start, where did they originate, where do they spread to, those kinds of things. By doing so, we then start to think about and plan for what would be great opportunities for surgical intervention. Well, there's a lot of new technologies coming out. Many of these all within the last just couple of years, but we're now starting to be able to identify better what we call source localization. So where is that seizure origin? Is it deep? Is it on the cortex? Is it in areas that we couldn't previously imagine? We're also getting better at our anatomic imaging. As I mentioned, we're now able to see abnormalities that we couldn't see before. And so that has become exciting, especially for a surgeon, because the reality is even what would look like a very abnormal MRI may look like normal brain when we're operating on it. And then functional imaging has also markedly improved. The definition and the visualization of areas of abnormality, now we can start to pick those out. And then ultimately, what we call multimodal approaches, where we take all of that data, we try to create what's called concordance. So matching up those different areas has really been exciting in our ability to now map one set of images onto another and give us better mapping, I guess is the best word, for those particular areas. And so I'll show you that in just a little bit. So here's an MRI, what would look like an MRI when I first started. And this looks like a normal MRI and probably would have been read out as normal. But as we improve our MRI sequences, now you start to see some potential differences from side to side, and I'll put little circles around it, and you can clearly see now what looked like a normal MRI is not really a normal MRI. So now this is something that becomes a potential area for us to target and think about as an option. So our MRI sequences have gotten much better at identifying abnormalities, particularly different areas of cortical dysplasia, areas where the brain didn't form properly, previous strokes, tumors that are maybe early in their evolution. These are all great opportunities that we see with our new imaging. Similarly, we can now take these images and create these 3D approaches. And in this particular case, now what we're doing is an analysis of a patient's whole cerebral cortex and mapping that relative to other normal MRIs. And so here in this picture, red indicates that these are areas of cortical thickness that are abnormal, that are 2 standard deviations above normal. The purple is an area which is the motor strip, so now we can match up areas of abnormality to what we call eloquent areas, so areas that we want to try to avoid. And what you're seeing with all the green dots, that's a grid and some depth electrodes that we placed in this particular patient. And now we mapped on where those electrodes were. Now we also can see where there's anatomic abnormality. And when we have those electrodes inside the skull, we can now start to look at the function of the brain and map it out onto the brain itself and see where those abnormalities are. So this becomes a much greater picture for someone like myself to be directed. And in this particular case, we saw EEG abnormalities coming off the grid towards the front there, and that really matched up to an area of cortical thickness and cortical dysplasia. So again, you can see, even with this type of imaging, you can see from the back of the room where we can now think about creating surgical direction for ourselves in order to try to treat these patients. Well, similarly, we've got improved areas of functional imaging, and obviously I can't go through all of them, but since epilepsy is a functional disease, our goal, really using a combination of these imaging, allows us to map out onto the brain where there's a network problem. So normal functioning brain has a different, let's say, metabolism and cerebral blood flow and electrophysiology than the abnormal network. And so we utilize those differences with these different functional modalities, and being able to know where normal is and now start to see areas of abnormality. That's how we sort of cross-reference and start to, again, create a surgical plan. So I'm just going to touch on some of the more recent work. Functional MRI has been around for a while. You may have heard the term task-based functional MRI, and that's where you lay in the MRI. They have you either talk or tap your fingers or tap your foot or things like that, or say or count. And what that then does is it increases the blood flow to that part of the brain, and that difference is what the computer can then spit out what the function is. Well, the reality is that we can't take a 6-year-old, put them in the MRI, and have them lay still and follow a task. I don't think I could get my 16-year-old to do that. So the reality is that this is a very limited study, mostly in adults. And so, but it gives us great images. Here's a patient who did a task-based MRI. You can see in this case the motor area, so finger tapping, hand movement, things like that. The orange represents the changes in blood flow for the hands. And now you can also see on the right side of the brain there, well, it's the left brain, but on the right side of the screen, this area, and you can see the relationship of that where the normal function is to the, in this particular case, brain tumor. And so indeed, this is a great test if you can get it. Now, again, as I said, it's difficult in kids, and so there's been the emergence lately, and so this is one of the new innovations, has been what's called resting state functional MRI. This is a situation where you could do it actually in a sedated child, and what you're looking for are all the normal networks, again, using certain blood flow schemes that we can pick up in the MRI, and then map the normal ones and then see where there's abnormal ones. So again, this is the way, comparing normal to abnormal, we're now able to pick up differences in functional networks. And these are the known functional networks. This is just a great example showing, for example, visual, motor areas. And so these are what we would expect would be normal networks. Here's one showing language networks. Here's left hemisphere, so these would be normal language on the left with non-dominant language on the right. And so here you can really tell and understand where the normal networks are. Well, then you compare and contrast that to, here's a patient who had what looked like an abnormal network in the left temporal lobe. On the right side of the screen, that sort of green and purple blob, I don't think my arrow shows up, no. So here is an instance where we were able to pick up that the seizures were coming from the left temporal lobe. And so similarly, as I said, we have this type of test, we have some of the other tests, we can bring that all together for being able to diagnose these patients. So here's a 17-year-old young girl with intractable epilepsy for a long time, really since early life, failed different medications. You can see sort of the workup there. And then here's what we call our multimodal approach. Now we can map out her EEG, both the low density and the high density EEG, to show where some abnormalities are. Her MEG, here's her PET scan with the arrow pointing at the area of low metabolism. Here's her stereotactic EEG, so she had depth electrodes placed in order to target, and that's where the targeting came. And then you can see we were able to do a much more focused epilepsy surgery, in this case using laser ablation, in order to try to treat this patient's seizures. And so this is just a compilation for one patient, how we're able to map all of the information into a set of images that allows us to do a much more focused, targeted surgical treatment. Well, that helps to segue into where surgery has gone in the last few years. I'm going to date myself a bit. So when I first came out of training, this is kind of what we could do. We had temporal lobectomies, we had other types of resections, we had anatomical hemispherectomies, and then we could do a callosotomy, and then last ditch effort we would try these sort of MSTs, multiple subpial transections. The fun thing about working in neuroscience over the last 25 years is that things do evolve, and luckily I can evolve, so the old dog can still learn new tricks. So we don't do anatomical hemispherectomies. It's evolved now to a cerebral hemispherotomy, which is a much smaller operation, much better tolerated, and we can do these in children as young as 3 or 4 months of age, where anatomical hemispherectomies, many times we had to stage them because of blood loss. Similarly, we now have at our fingertips the use of ablation, so laser ablation, radiofrequency ablation, other types of ways of doing very small targeted areas. And then there was no field of neuromodulation when I started. Obviously VNS came out in the mid-90s, and these other ones have been coming out over the last few years. I think it's really an exciting time because indeed we can see a lot of these new technologies that you'll probably see in the next few years. Transcranial magnetic stimulation. I forgot to include trigeminal neurostimulation, focused ultrasound, and in the far future, maybe even transplantation. There is research work in all of these different areas, which is very exciting. The reality is we would like to cure, and when we look at our data when it comes to resective surgery in the appropriate patients, I mean, we can do very well. And Dr. Holder remembers this slide because this is from the mid 2000s, where we really had wonderful results with targeted patients. We know that if we can lateralize and then localize these patients, they do better. We know that mortality is less with surgery than with continued failed medication, and we know we can do these surgeries with low complication. But not all patients are going to be able to be targeted for treatment like this, and that's something that we have to consider. As a result, we have evolved with that, and so I'm just going to talk a little bit about some of the more minimally invasive approaches that we can do. Many of you are familiar with laser or lit therapy or stereotactic laser ablation. In these instances, we use a 3mm incision. We're able to place the laser probe in an area that we think is abnormal or causing the seizures or is the source of where the seizures are coming from. We then, under direct guidance in real time, watch while the area heats up, and then it's a computer calculated cell death calculation. So what you'll see is the actual area that is planned for ablation growing over time, and our ability to limit that growth is based on temperature and time. And so it's going pixel by pixel, which allows us to do a very targeted and very fine type of ablation. It started in hypothalamic hamartoma because it was a very targeted area, and I'll give an example of that now. This was a 14-year-old young woman from Hawaii who came to us who had gelastic seizures really since early birth. She continued to have about 6 seizures a day despite medication. Her evaluation was, for the most part, normal. Here's her MRI, and the arrow is pointing to her hypothalamic hamartoma, but the MRI also revealed how close that lesion, to her mammillary bodies, which are very important for memory function. If you damage one, people can function without a single side, and that's the principle of temporal lobectomy. But if you damage both, the patients really do have a devastating neurologic injury. And so to do this as an open procedure or through an endoscope really puts at risk, in this particular case, the mammillary bodies or her memory function. Here's just looking at it from the side, showing not just the hypothalamic hamartoma, but the fornices, which are where the mammillary bodies connect to. In this particular child, we did a resting state functional MRI, and so it not only showed us which way, where the seizures were arising from, but also what's called its directionality. And so we knew that on the top of the lesion and toward the back of the lesion was where we needed to target if indeed we were going to interfere with the seizures. So this is our laser probe in place, and you can see, looking at it from the side, you see how our probe is targeted. We're just above the mammillary body. And then this is the post-ablation map, that orange area right in the middle. You can see we're staying away from the mammillary bodies here, so we can do this really quite safely. We're able to disconnect this area, and this child's now 2.5 years out with no further gelastic seizures since surgery. So again, this is a patient that it would have been very, very difficult to do this prior to the development of this technology. Clearly, this has added a significant improvement to her quality of life. And so, again, for the appropriate patients, this is really a great technology. When it comes to neurosurgeons, when you have a hammer, everything starts to look like a nail, so we look for other opportunities for utilizing this technology. This is a child with mesiotemporal sclerosis, so with left temporal abnormality. We saw that on all the different modalities that we tested. Here's her MRI pointing to the left temporal lobe as a source, and then this is the laser ablation map. You can see the area of the temporal lobe that we were able to ablate, and this child too was seizure-free now for 1.5 years after this laser ablation. This is the MRI we get afterward, which shows the area of swelling where we heated up, so it correlated with our damage maps, and then we also did these T1 with contrast again to show where the ablation was done. And again, what's most important is that this child remained seizure-free. Well, we can also do this for cortical dysplasias. In this particular case, we're able to identify and target area of abnormality in the right frontal region. You can see here, the ablation maps and then the post-op MRI. This required 3 probes. The other 2 cases I showed had a single probe. So we can put in upwards of 3 or 4 probes in order to try to achieve this ablation. And all of these patients, for the most part, will go home the next day. So it's really in the more complex where we do 3 or 4 probes that we may consider keeping a patient an extra night. But most of these patients, we used to send them to the ICU because we were worried we'd cause a lot of problems and issues with swelling, etc. But the reality is that now all of our patients just go to the floor because we already have an MRI afterward that shows the extent of the ablation, that there's no bleed, and that everything looks good. This is another patient who has Lennox-Gastaut with atonic seizures, so drop attacks, multiple seizures per day, has tried a number of medications, including the diet and vagal nerve stimulation. This was corpus callosotomy, is a perfect candidate for a corpus callosotomy. This would be the surgical view. The two purple lines at the top would be the extent of the bone removal for a period of time for the surgery. The view with the triangle would be our way that we would target this area. Under a microscope, this is what you'd see. This is the normal corpus callosum, with that being the front and the bottom being the back. And then you can see the division of the fibers, leaving the ependymma intact. Truly one of the really beautiful aspects of the anatomy of the brain and our ability to really make a difference for these patients. But with improved technology and these innovations, now the question becomes, can we use the laser to do the same kind of thing? And indeed we can. Here, this patient required 3 laser probes, but you can see the damage map for the front of the corpus callosum, part of the body, the front part of the body of the corpus callosum, and then the posterior body of the corpus callosum, including the splenium. And so, again, in this patient, we were able to do a complete corpus callosotomy without having to do it open. Now, not all patients we can do this, because this particular patient's corpus callosum was very amenable because it was fairly straight, because we can only have straight probes at the moment. In patients who have a more rounded corpus callosum, it's much more difficult to do that. On the other hand, we've had some evolution in our thinking, because in these instances, very frequently what we can do is, if it fails because we missed an area or the probe wasn't able to go to a particular area, we could always come back. And excuse the pun, we didn't burn any bridges. So we can go from there. And then this is just the post imaging on that particular patient. We can do laser ablation for other lesions. This is a patient with metastatic astrocytoma. In this instance, we were able to target this area, ablate it. And so the laser has really come on in the last number of years in our ability to go to areas we couldn't do before, with pathologies we couldn't do before. This is a patient with a cavernous malformation, for example. Alrighty, so I'm going to move on to neuromodulation, which you thought you were coming to today. So I'm going to talk a little bit about some of the new innovations, and just want to talk a little bit about the challenges first. The reality is I showed you very discrete areas of seizure abnormality which we could target with a laser or target with a surgical resection. Many times, unfortunately, the seizures aren't so clear-cut, and sometimes they're not in a nice targetable area. And many times they're diffuse, they can be bilateral, and they can also be right in the middle of someone's eloquent area, motor area of the brain, where the morbidity from the surgery would be really unacceptable. And in those instances, neuromodulation could potentially be useful. Again, when I said bilateral, again, hippocampus is a great example where I talked earlier about the mammillary bodies. We can't take both hippocampi, and so in that instance, a patient would more likely benefit from neuromodulation. Now, there's a lot of different discussion about risk and benefit, and I'll go through these. Obviously, something like a vagal nerve stimulator, very, very low risk, potentially high benefit, and so that is often our first line of attempted treatment, with then more invasive type of neuromodulation as it becomes more and more complex and they've failed other types of therapy. Well, this is kind of where we're at right now. We used to just either add more medications, and if we had patients who would benefit from a resection, we could do that, but there was really nothing in between. And now with neuromodulation, we now have something that can fill that gap. Is it going to have as great a seizure control as resective curative surgery? No. But is it going to be better than additional medications? Absolutely. But it is more invasive, and it does require implantation, does require a surgery, but less invasive than doing a resective surgery or lobectomy or even a laser ablation for that matter. So as I mentioned, there's a number of different modalities, and I'll start with the VNS. We don't really consider this surgery. It's basically an implantable medication. Your neurologist will change the dosage, the frequency of the stimulation, the time of day, those kinds of things. It is easily managed by your neurologist, but I've even in rural areas, we've worked with pediatricians and family practice doctors in order to give them the parameters necessary to change the dosage frequency and those kinds of things. So this is really a particularly wonderful device. What we found in Arizona was that indeed there was less access to care for patients with vagal nerve stimulation. Mostly it was because of the lack of education of the family practice and pediatrician doctors out in those rural areas. And so really hopefully through this type of venue, we can raise awareness for these doctors who can then become participating in the care of the children and adults that are out in these rural communities. This is just an overview of the procedure. It's 2 incisions, one in the neck and one in the chest. The one in the neck gets the electrode leads. The one on the chest is the pacemaker. Takes me about 45 minutes to do these procedures, and the patients go home about an hour or 2 afterward. They go home just with Tylenol or Motrin, sometimes alternating. It is not that painful a procedure. It's really very well tolerated, and really it's one of those really unique procedures that has made a significant impact. This is just a surgical view of kind of what we see. And unfortunately, I've been around long enough that I've tried every one of these generation of generators. The more recent technologies are really fantastic because they pick up heart rate. So you may have heard in some of the other sessions for patients when they start to have a seizure, heart rate goes up in the majority of cases. In those instances, if you've got a device that can sense that heart rate change, it can now then give an extra stimulus like a rescue med. It can give that extra stimulus and then hopefully either diminish or stop the seizure. And there is literature that now supports this for close to 10,000 seizures. About 40% will be diminished and about 25% will be terminated. So indeed, having this type of technology with this type of on-demand treatment, and you can see that in the EEG over to your right, you can see a patient who's having a seizure. They got the stimulus at that dark black line in the middle, and then you can see the EEG got much better. So again, doesn't work for everybody, and that's clear, but with this advanced technology, we can do much more than we could do particularly when we started. This auto stim mode really is in response to the heart rate, and that's really because we know that heart rate and that the heart and brain are connected. When it comes to having a seizure, your sympathetic activity goes up. Your sympathetic activity is your flight or fright type of response. Your heart rate goes up. It reads that. It gives an extra stimulus. I'm going to see if this is going to work. It does. So here's the normal background heart rate that you see. You can see it kind of tootling along there. There, the heart rate went up, and there you can see the stimulus. Heart rate is up again, and then everything else comes back down to normal. So again, this is a typical of what one might see in these particular patients. If I can now get out of it. How about the next one? Okay, so anyway, as I showed earlier, these type of stimulations can truly lead to reduce the seizures, and we can kind of go from there. These are the outcomes. The nice thing about VNS, it's been around a long, long time now, over 25 years. And we can see that unlike medication, which loses efficacy over time, the VNS efficacy goes up over the first couple of years and is maintained even out to 5 years. We're now seeing, upwards of 50 to 65% of patients who will continue to have a response even, 5 years out or more. So again, I think that this technology was really revolutionary in changing the perspective of how we need to start to look at these patients. I'm going to move on now to RNS, responsive neurostimulation. In these instances, these are patients that are, in most cases, again, unresponsive to medical, dietary, or alternative treatments. Many instances, they've also failed vagal nerve stimulation. It's for the most part indicated in those with poor control. It has two components. The wires are in the brain rather than in the neck in this instance. And then also the generator is implanted into the skull itself. And the reason for that is you want to create what's called a closed loop system where it reads the EEG and then gives a stimulus, and you want the shortest distance between them in order to try to interfere with that. Excuse me. So how does it work? Well, ultimately, as I mentioned, it will read the EEG. Your neurologist will be targeting that particular area and that particular abnormality. It will then have a response for that EEG and then hopefully interfere with the epilepsy. Again, sorry it's after lunch, but this is what it would look like surgically with electrodes in the surface and then the generator that's implanted into the bone. These are early pictures. I haven't seen it look like this since I've been doing it, so just want to reassure. But again, this is typical of what you'd see, which are the wires coming out from the brain and attaching to the generator. Many times, the reason for the very large incision in this right-sided case is because that the electrodes are placed all within the same incision. Many times we're making two small incisions to place the electrodes and then just an incision sufficiently to get that generator into the skull. Well, there's a lot of great data with regards to adults, but unfortunately many children, there were no children involved in the pivotal studies, but I think you'll now see over the last 5-7 years a lot of papers that have come out in this regard. RNS for children is off-label. It is not FDA approved for children, but except in exceptional cases, we do use it off-label in order to do that. This is an example of really a nice response. This was an 11-year-old who really did not respond to medications, diet, vagal nerve stimulation. Here's her she had the gamut of workup. Here's her MEG, and you can see the purple arrow pointing to the parietal area where her seizures seem to be coming from. But you can also see the red splotches on the left, again, temporal and parietal. And so in these instances, she has bilateral seizures, really a reasonable candidate for RNS, and she's failed everything else. This was her final configuration. You can see the two electrodes and the generator here. And then what you'll see is that you can actually read when they're having activations. And so you can see when she's having seizures, and so that green bars are when she's having seizures. This child did really well. She's now in Angle 1, so she's had a greater than 90% reduction in her seizures. She's being weaned down to just one medication. She was on 3 medications. And she's had a very, very nice semiologic and seizure outcome that we can see. But interestingly, despite that, she's still continuing to have significant seizures. So I just want you to remember this graph because I'm going to show a little bit of a contrast to this in just a sec. So moving on to deep brain stimulation, that's where we're placing electrodes really into the deep parts, into the sort of the signaling area down deep into the brain in the thalamus. Now, DBS has been around for a long time, mostly for Parkinson's and other types of movement disorders, but now it's really taken on a new life when it comes to epilepsy and was recently approved for adults with temporal lobe epilepsy to target the anterior part of the thalamus, which is a deep structure in the brain. But there are also patients with the RNS, and again, can we start to look at marrying those two technologies in order to provide more optimal care? So again, the thalamus is a kind of a switching station for much of the brain. It's why it's very, very important. It's called the diencephalon, and all of our connections go through the thalamus, and so it's a central connecting area. And so if we can target different areas based on where the seizures are coming from, potentially we might be able to improve their seizure outcome. Well, there's now deep targets that have been shown in a multitude, including parts of the thalamus, the anterior thalamus, pulvinar, centromedian. These are just different nuclei, and this was this particular group's experience with regards to it. Well, we had a patient that we felt that this would be a good try for. She had unfortunately developed autoimmune encephalitis, was an in and out of status epilepticus, was unresponsive to medication. She also was tried on everything, meds, diet, vagal nerve stimulation, really without any improvement. Her workup showed bilateral involvement, so we placed SEEG electrodes to see if we could target things more directly. Here's just the electrodes on the 3D images, again, to try to give us some targeting. In this particular case, we were looking at high-frequency oscillations, which is a very abnormal electrical activity within the brain, and we were able to identify which contacts and which electrodes were the hottest. You can see those little squares there are the ones that we were targeting, and similarly the squares here, but you can see it's bilateral, front of the brain, back of the brain, and we only have, unfortunately at the present time, 2 slots within the RNS system to target. So we targeted a deep target, which was the centromedian nucleus here on the CT scan. Here you can see the X-ray configuration. There's also an electrode under her right temporal lobe. And this is her map. And so you can actually see her map where she had a lot of seizures to begin with, but at the end, she had very, very few seizures being picked up by the electrodes. So this would look like an absolutely fantastic outcome, right? Except that she's an angle 4, and meaning that we've only got about maybe 25-30% reduction in her seizures. Well, why is that? It looks like our EEG looks much, much better. Well, as I mentioned, she has multiple foci. So where we stimulate, we're doing great, but it was probably only causing 25 or 30% of her seizures. So we controlled those. Now how do we figure out how to control the rest of the abnormal areas? It's probably going to require more electrodes, and so that's where we have to decide on whether a further generator or our new generation RNS will help us. We have done this in children, and this was our first 22 patients. We're now up to close to 30 patients, and we are getting good outcomes. These are much better than what we would see with repeatedly failed medication. So we know what these children can't do. And so what we're now trying to do is push the envelope in order to see if we can get some modicum of control. For some of these patients, it's been an absolute miracle. For others, it's helped, but we have a lot to learn. And that's really ultimately what our conclusion is, at least in this early stage, is that we do have a lot to learn. While it is clearly improved outcomes for some of the patients, it's not curative. It can improve quality of life, but again, identifying the appropriate patients with the appropriate and optimal approach is really where we need to learn. And so these are some of the questions that still remain, but this is a technology that's only been around for the last 5-7 years, and we've only been putting them in children in the last 4 years. And so the reality is that I think we're going to get better, and when I return again in 3 years, then maybe I'll be able to give you even that much more information. So just to sum it all up, we all know that intractable epilepsy impacts not just mortality with SUDEP, but cognitive outcomes and quality of life. We know that outcomes from surgery are better as compared to continued failed medical therapy in selected patients. So I'm not saying that surgery is for everybody, but it should be combined with all the other treatments in order to stop the seizures, because that's really what our goal is. It's been absolute fun as an old guy to continue to be able to innovate and advance with the field. And I think that there are a lot of new opportunities for cure, which I showed with the laser ablation, but also ways that we can improve seizure frequency and outcome with the neuromodulation. Could not do it without a great team, and I truly appreciated working in Phoenix with this great group of individuals. Now I just hope to go on and build that in West Virginia, so look forward to anybody who wants to come in that direction. So thank you. Happy to take questions if anybody has. Yes, sir.
Hey, thanks for the talk. You referred to kind of there's an urban-rural disparity in access, and you mentioned just globally there's many more people that could potentially benefit from surgery than we're getting. And so besides the urban-rural access issue, what do you think is the rate-limiting step? Why don't more people access these surgeries?
Yeah, that is a fantastic question, and I think if you ask every surgeon, they'll roll their eyes immensely. I think that there's the urban-rural, which we studied in Arizona and saw that there was a disparity, and that's, it's access to care, and it's access to good care. Not to say that there's not, kind of standard work being done in these communities, but a lot of them don't understand or seen, the advances when it comes to epilepsy. They may have gotten there 1 or 2 days in medical school and now are out in the community, and a seizure, they may see one of them a year or something along those lines. So I think that there's education. Really, I think this is a great venue because the families get educated. Some of my referrals have been self-referred by families. There was a very young child, an infant, who was seizing from birth and went to a local neurologist and neurosurgeon and was told that they had to wait a year and a half before getting surgery because she was so small, and we operated on her at 3.5 months, and stopped her seizures completely. If she had waited a year and a half with 60 seizures a day, that child really wouldn't be as functional as she is today. So having said that, I think it's a multitude of reasons. It's doctor awareness, it's patient and family awareness. I think that's really when you see the zealots of doctors here and other professionals, nurses and psychologists and dietitians, all of them are really working not just in the area of their field, but also working to try to raise awareness, whether it's through social media or through websites and those kinds of things. So I would really, I think the Epilepsy Foundation in each of your local areas is a great resource. In all honesty, one of the reasons I was going to West Virginia was that I would be able to help develop a distributive model for neuroscience, and epilepsy is one of our targeted diagnoses that we plan to put into nodes and create access, so into rural areas, underserved areas. In West Virginia, I got the data, and it was telling me that only 10% of children with epilepsy were getting access to care in the West Virginia health system. 10%. And I mean, I'm going to really look good in 5 years. So you bet. Other questions that I can answer? Yes, please.
Question about the VNS data you shared. You said 62% of some change, some impact improvement of either cessation or improvement. Is that in adult or both adult and pediatric? Because I know VNS has been around a lot longer, and I know it's been approved in, it was first 16 and under and then up down to
It's down to 12. It's down to 12 and under.
Okay.
I've put them in children as young as 6 months of age.
Okay.
What I would say is that the data for children is still sketchy. I don't think we have great data. I've been trying to get Dr. Holder to publish her data.
Yeah.
She has a lot of numbers.
Okay.
So I think that the opportunity for understanding how well children do, not just seizure control, but development would also be important.
Yeah. I have one more, but I just want to ask a question, but I don't know how before.
No.
My other question is, what if a patient had epilepsy surgery and their seizures were not controlled? Where do these new techniques come in? You talked about a layered approach with, I believe, RNS and DBS, and I've got that right. So what would you be looking at for a patient where, we now have even anatomical hemispectomies, right, where there's clearly the connection, it's not a connection issue, or they feel like they did a clearly delineated resection of an epileptic zone. Where do these tools come in for pre-operation?
I think that the reason that a surgery would fail, or quote unquote not work, or the patient still has seizures afterward, is it was incompletely treated, or there's multiple other areas. So sometimes you can have a primary focus and then secondary or tertiary focus, so a second or third. And so now you cut off one part, but now the others become the primary. And so the tools, when we have a patient that doesn't optimally have a great outcome, then what we do is we repeat those studies to see if the area of the seizure is still coming from nearby where we were working, or is it something that's completely remote that we didn't see before, or that we didn't study before, or it didn't really show up before. And so that's really the determination. So we don't give up. I think the issue is, and because patients can tolerate surgery, and because these are more minimally invasive approaches, we try to find what's optimal. So if it's an area like a hemispherotomy where we missed a connection, we can see that with our advanced imaging through DTI. We can see connections. We might be able to either do that open again, go back in and take that connection, or in some instances, we're now just using laser ablation to get those last few connections. And so it's really, that's what's so great about the opportunity, because it's really for us to prove that it's not a surgical problem. And if we felt that it was a surgical problem and it didn't work as optimally as we wanted or expected, well, then we just go back and restudy and start to say the process over again, but to now bring in new information. Does that give us a difference of what we could potentially do?
Thank you.
Yeah, anybody who's had failed surgery, it shouldn't be a perspective of giving up. It should be, are we dealing with the same problem, or is this a new problem, and then how do we address that problem optimally?
Thank you.
You bet. Yes, sir.
Yeah, this is got me thinking, our daughter has LGS and kind of generalized seizures. I mean, is it the case when we describe generalized seizure activity across the whole brain, do you think that there is often a locus of kind of where this is caused or affected that hasn't been found, or is it the case really that there's just truly generalized distributed abnormality? And I'm just interested in your perspective on that.
And she did just recently have her corpus calcium done through laser, which was great,
Okay.
but not seizure. But yeah.
All right, but how about our atonic seizures?
A lot better.
Yeah. So first off, unfortunately there can be diffuse. So oftentimes in the genetic epilepsies, it's something that the whole brain is affected and firing. And while there still can be focal areas of source, most often the connections are kind of inset that, to have that hyperactivity or loss of inhibition or things like that. That still doesn't mean that there aren't surgical treatments. So as I said, we would start with, most often in those instances, of VNS, but that's really where this later, if that failed, where the DBS RNS kind of hybrid approach with, so when you have a generalized type epilepsy, placing electrodes into the central processing area, the thalamus, potentially could be an opportunity to stop those. If there's a particular zone of abnormality, then it could be electrodes on both sides of the brain in order to kind of change that perspective as well, change that network. Again, without seeing your daughter, I mean, I'm kind of going through the gamut here, but we don't, I think the calosotomy is a great first step, and the reason for that is that it disconnects the two sides. And by disconnecting the two sides, then you can start to see whether there's more focality on the right or the left. Does that allow you to now start to focus your hypothesis that, you know, the left was really driving the right, the left is a problem? How can we address it? We might be able to do it with something like an RNS. Now, whether it's surface and or depth electrodes, that remains part of the SEEG aspect of it.
Thank you. That's very helpful. Thank you.
You bet. Anyone else? Well, great. Well, you guys enjoy the rest of the expo. Fantastic. Thank you for being here.
Thank you so much.
All right.